Good afternoon. At the outset, first of all, I would like to thank team of Diabetes India, especially Dr. Banshi, giving me this topic. Of course, it's not my cup of tea, frankly speaking. I'm working as a socio-academic work for Type 1 for the past 20 years, and this is purely a theoretical topic. I think when I started our practice 25 years back, that time the Type 1 means insulin. That was the only thing. Whenever we are talking about the Type 1, it is only insulin is the treatment. But now the things are new, things are coming. Is there any other modalities are there? That yes, there are a lot of studies and a lot of things are there, especially in Indian subcontinent. That's why the few drugs are trialed in Type 1 diabetes. So briefly, I will uh, describe some of the drugs and their studies in Type 1. Uh, why beyond insulin in Type 1? Clinical need, not novelty. The goal is not replacing insulin, but reducing total insulin exposure while improving time in range. The, the thing came because now the type 1 diabetic become changing, become they are obese. Now there is a double diabetes is there. Even with the modern basal bolus and pump therapy, many adults with T1D remains above target due to postprandial spikes, weight gain, insulin resistance, especially double diabetes, fear of hypoglycemia, and suboptimal glycemic control in many patients. Adjuvant non-agents to reduce glycemic variability, glucose doses, weight, and carbo metabolic risk. This is story especially for India because there's a rising obesity, variable access of CGM and ketone testing, and high decay burden makes benefit risk selection central to any off-label strategy. The pathophysiology is already discussed about it. There is increasing insulin resistance even in type 1 diabetic patients. There is a post-prandial hypoglycemia because of the high carb diet in Indian subcontinent, renal glucose handling independent of insulin, and amylin deficiency. These are the drugs which were tried and studied, and a lot of studies are there. All these OHAs, metformin, GLP agonists, SGLT inhibitors, DPP4 inhibitors, amylin analogs, immunomodulating drugs and cellular therapies discussed by Dr. Stephen, and in few studies, AGAs. India, the epidemiology and phenotype shift, that is lean T1D to T1D plus metabolic syndrome. As Dr. Archana already told, 25 years there were hardly any adult or type 1 diabetic in that particular area, and especially in our part also, we have not seen hardly a 30, 40-year person in 25 years back. But now people are living longer and they become little bit getting the metabolic syndrome. So registries and clinical expert experience increasing shows adolescent and young adults with T1D developing overweight, dyslipidemia, and FLD, hypertension, creating a phenotype where insulin alone worsen weight insulin resistance cycle. So this is the primary real world driver behind metformin GLP-1 adjuvant prescription, especially in India. Double diabetes, one side there is a insulin deficiency because of autoimmunity, another there is a insulin resistance. This is classically seen nowadays in some of the patients. uh, Effective management requires a multifaceted approach that addresses both insulin deficiency and insulin resistance. Most commonly tried drug was metformin because it improves insulin sensitivity, useful in overweight and T1D and obese T1D, and reduces the insulin requirement. This is a very why metformin is a common adjuvant. It is inexpensive, familial, and targets insulin resistance and weight. Hence, it's frequent off-label use in overweight T1D adults. The key is expectation setting. Metformin is not a durable A1C lowering drug in established T1D, but may reduce insulin dosage, weight, and LDL modestly, especially when combined with structural lifestyle and TGM feedback. This is a very popular removal trial for 3 years showing metformin did not sustain A1C reduction long-term adults with T1D, but did show modest benefits and weight and LDL-C informing the metabolic exuent rationale rather than glycemic targets. SGLT2 inhibitors widely studied in type 1 diabetes in many of the studies, and the mechanism fits in T1D, but does the increase the risk of DKA. That was a major side effect and major challenge. So dual ACE mechanism SGLT2 inhibitors reduce renal glucose reabsorption independent of insulin, improving postprandial control and weight, but they also increase ketogenesis risk, especially with the insulin dose reduction, low carb diets, dehydration, illness, missed insulin, or pump failure. So these things can lead to the increase the decay. There are a lot of studies with DAPA, depict 1 for 24 weeks, showing efficacy signals. Depict 1 demonstrate that adding DAPA to insulin improve glycemic control and reduce weight in adults with T1D, supporting the glucose variability plus weight use case. Depict 1 for 52 weeks, that's showing glycemic and weight benefits persist, but adverse event remain the limiting factors. Another study depict 2 for 24 weeks. That's incremental A1C improvement, weight reduction, and insulin dose lowering. Again, counterbalanced by ketosis and decay. Of course, there are advantages, but it is countered by again ketosis and decay. The best way to present this is an phenotype specific tool, that is overweight, high insulin, and high variability, rather than a general T1D add-on, especially in Indian subcontinent. EMPA is also used in some of the trials, EASE trials, and it's showing that low dose was more useful and less complications, less decay with low doses as compared to 10 and 25 milligram. 2.5 milligram was showing good results. So the low dose learning is showing EMPA improving glycemic and weight in T1D. Importantly, the very low dose arm helped frame that hypothesis that smaller SGLT2 doses may reduce decay liability while retaining some benefits. Other drugs which were tried also, sotagliflozin, which is dual SGLT1, SGLT2 both. It's covering the have both the effect on both. So it postprandial advantage concept by dual inhibition adds an intestinal component that can blunt the postprandial excretion. So an appealing idea for high carb dietary pattern. The decay problem is very common with these drugs, especially in euglycemic decay. So consensus risk management guidance recommended for these steps. First, ketone testing during illness. If you are trying these drugs, check ketones whenever there is getting any illness, especially unexplained fever, reduced intake, or nausea. Avoid large insulin cuts. Gradually dose reduction with dose monitoring. Stop drug, especially before surgery or during surgery, because it can lead to decay. And act early. If any sign of decay is there, any sign of ketosis there, start immediately insulin, fluid, and carbohydrate to treat that decay. Another drugs which were tried was GLP receptor agonist, Lira and Sema. Both were tried as an off-label. They are appetite suppressant and slow gastric emptying. One of the GLP receptor agonists are not FDA approved for type 1 diabetes, but are used off-label as adjuvant therapy in insulin to reduce body weight, total daily insulin requirement, and improve glycemic control, in particular in patients with insulin resistance and obesity. Evidence shows that they may help stabilize glucose level and reduce the A1C, although results are inconsistent. Adjuvant trial, adjuvant 1 with liraglutide for 52 weeks, showing liraglutide added to insulin reduced A1C, modestly lowered insulin dose and reduced weight, but increased symptomatic hypoglycemia, and high dose arm increase the hypoglycemia as well as ketosis. So GLP-1 agonist adjust may be considered only in selected overweight adult with CGM, careful insulin titration, and explained ketosis education. Otherwise, risk overweight the benefits. Another adjuvant 2 trial with liraglutide showing demonstrate that although liraglutide is effective, the increased risk of ketosis and hypoglycemia limit the widespread clinical use in type 1 diabetes. Amylin analogs, that is pramlintide, which is a physiological missing hormone, which is very well used in past many years. This pramlin represents a physiological missing hormone story in diabetes management because it replaces amylin. That is a hormone co-secreted with insulin by pancreatic beta cells that is deficient or absent in patients with diabetes. While insulin therapy manages basal glucose, amylin deficiency contributes to postprandial hypoglycemia, excessive glucagon secretion, and reduced satiety. So pramlintide is an analog that missing hormone was approved by US FDA and adjuvant to mealtime insulin to restore this physiological balance. This drug, we can say it is the most widely accepted in T1D specific patient because this has a definite role. It mimics the endogenous amylin, decrease gastric emptying, decrease glucagon secretion, and decrease postprandial glucose. So, especially in Indian subcontinent, uh, problem is of cost and availability, but it remains the most T1D specific adjuvant conceptually. AG has also tried in some studies this old drug specific niche acarbose can reduce postprandial excretion in T1D by delaying carbohydrate absorption with minimal hypoglycemic risk unless insulin dosing is mismatched. The limitation of GI intolerance and adherence. DPP-4 inhibitors, they are not routinely recommended, but sometimes tried in real life where weight neutrality and safety are valued while acknowledging limited glycemic payoff. Beta cell preservation adjuvant to new onset T1D. Uh, Teplizumab is already discussed by Dr. Stephen, which is widely used. And the another drug which was tried in some of the studies was verapamil. Teclizumab is the anti-CD3 monoclonal antibody, delayed onset of high-risk individuals and not for routine glycemic control. This delay the clinical T1D while not a treatment for established T1D in insulin. So teclizumab changed the conversation by demonstrating that immunotherapy can delay progression from stage 2 to stage 3. There are a lot of studies already discussed by the first speaker, highlighting that early identification, that is autoantibodies and dysglycemia, could shift care beyond glucose control alone. So how to present adjuvant therapy ranking in national endocrine audience? First, metformin, metabolic benefit, but limited A1C durability. SGLT2 inhibitors widely used, best glycemia, weight signal, but DK limitation. GLP-1 analogs, weight benefit, but hypoglycemia and again ketosis the most A1C. And pramlintide postprandial physiology, but availability, cost, and usability. So the key message is insulin remain the cornerstone. Insulin is a lifeline for a type 1 diabetes. Adjuvant offer metabolic benefits. Safety and individualization are essential, and evidence is evolving. Thank you very much. Thank you.